part of our economy that's carried us so many times, and without health care, I cannot imagine where we would have been. And so it'll be good to learn from them about their insights. And also, before we go too much further, I want to acknowledge we've got with us this morning James Brown. There he is. Raise your hand. James is a tremendous partner for us. We appreciate him. And he's the guy who never steers away from the good, the bad, and the difficult. He's always right there. So James, I say that because we really do. I appreciate you. Thank you for being with us. I know Brenda Neris, Councilwoman, signed up. I'm not sure she's here yet. Stephanie Nelson with Senator McConnell's office will be joining us. And I do say I forget to recognize my bosses. I don't know. I know we've got several of you here that are on the board of directors, and we appreciate you very much. Thank you for taking the time to come out and be with us today. So the first thing I would like for us to do now, let me raise your hand if you have an open spot at your table. We've got a few folks in the back that was at one point, okay, so I'll have staff kind of look around. Okay, good. That'll help us when we got folks coming in to make sure they've got a seat. So now I'd like to ask Jeff Zinger, who's the Lending Manager, Growth Markets, and Senior Vice President at WealthSouth, to come forward to make some comments. Jeff, and I gotta say, as Jeff comes up, we've always tried to figure out how do we make Spotlight work like this. Every time we have one, we have a great event, but this is a real CEO who's who type event, and we really appreciate you all taking the time to be here. And with that, I'll turn it over to you.
Good morning, everyone. Thanks for being here this morning. What a great crowd. As Bob said, my name is Jeff Zinger. I'm the Senior Vice President at WealthSouth. For those of you who don't know, WealthSouth is part of Commerce Bank in Danville. But we operate here in this community as WealthSouth. We're a full-service commercial lending group, institutional services, wealth management, trust. Great to be part of this community. These types of events are really important for us to support Lexington. We're so thrilled to have the panel here today. This is a wonderful group, and I'm really looking forward to learning some about our regional healthcare system today. So thank you for being here, and you all have a great day.
Thank you, Jeff. So just kind of an opening comment to make before we have our four CEOs come forward. Our region's healthcare system, I think sometimes, this is one industry I don't think we do take it for granted. I think many that we do just because they're there, they're part of this. So many of the folks here in the audience who are part of different hospital groups, you're part of the fabric of the community. So one of the things that I hope we never do is take our healthcare system for granted. What we have in front of us, and we are able to survive and to prosper, is we have consistently ranked. Our health system is one of the best, not only in the United States, but in the world. Think about it. When you see healthcare all over the world, it's pretty substantial. But the quality of what we have is highly recognized and noted a lot, and continues to be. Our local healthcare system, when you look at the infrastructure, it continues to grow and have a very strong presence here. When Jenna Greathouse and her team, and our whole team, when we're out, Tom Harris, Dr. Capelluto, Chicago, talking with site consultants, it's what's important. They already know our strengths. They already know what you're going to learn and hear more of. And what I assume you probably already know too is that we have a stellar, high-end healthcare system. And access to healthcare is extremely important, as are many other factors. That being said, access is important because it helps individuals and communities to grow and prosper. And also it helps with our social and economic development aspects of our social and economic development. I mean, just think of two things. 2008, we had one of the worst recessions in the history of our country. What carried us? A major part of that was the healthcare system. We all know about COVID-19. I don't have to even say a word. We lived through it, we're still living with it, and we probably will for generations to come, if not forever. And what was the fabric, what was the piece that kept us safe as best as could be done and carried forward? It was our health. So at this point, what I want to do, we want to hear from the four, and most of these folks are fairly new. in their roles, and so it'd be good to get some insights about what they're doing, but also some of their thoughts about Lexington. So, as I mention their name, I'm going to have them come up here and take a seat. First of all, the president from Baptist Health Lexington, the president, Christopher Roty. Come on up, Chris. Dr. Anthony Houston, CEO of CHI St. Joseph Health. Dr. Stephen Behnke, CEO, Lexington Clinic. And Dr. Robert DiPaola, CEO, Provost, and co-executive VP for Health Affairs. Thank you all. Go ahead, sit down there. Go ahead. Now, what I want to do to start with, just to kind of get it flowing, I know you all have on the back of your agenda bio, a little short bio. But I'd like for each individual up here just to take 30 seconds or less or more, whatever. Just say what is it that you want the audience to know about what got you here in your professional career, and maybe any other thing that we might not know. Let's start with Chris. Okay.
Well, glad to be here today. I'm Chris Roty, president of Baptist Lexington, as Bob mentioned. So what brought me here was Baptist Health. I've been with Baptist Health for 30 years in various markets, Louisville, LaGrange, Paducah before I arrived here, but unfortunate circumstances with Gil Sisson's death unfortunately opened up the door here, which is not the way I want to land here, but that's essentially how I did come here.
Tony.
Thanks, Bob. Good morning, everybody. Tony Houston. I've been with St. Joe's now since April of 21, but I've been in our company, Common Health, for 9 years. I was in Chattanooga, Tennessee with our company before. I'm from Cincinnati, so this is as close as I've been to home since I've been in this business. Chris and I shared something in common. We both went to Xavier, graduate program in health administration. But my father's from Rockcastle County, so I spent my summers in Kentucky, and this feels like home to me. I shared the story before, but when I got the news that I was going to come to St. Joe's in Lexington, my mom had tears. You could hear it on the phone, and she said, "Talk to your father." When my dad got the phone, my mom said he actually had tears in his eyes, and I asked Dad about it later, and he said, it was really joy because I knew you were going to get me tickets to UK basketball. So I'm thrilled to be with my son.
Steve.
Good morning, I'm Steve Behnke. So I grew up in Jessamine County. I'm from Louisville. And so I went to Asbury for undergrad, and then University of Louisville for med school. And then was pulled to the Ohio State University for residency. Lived in Columbus for about 20 years or so. And about 2 years ago, Dr. Henderson retired from the CEO position. And I had been working kind of through the practicing physician pathway, but also in physician leadership. And so my lane, these are all hospital folks, but I'm a physician enterprise person. So the Lexington Clinic is a physician practice, basically, large physician practice. And so when I thought about what I do as my world and what the Lexington Clinic needed was physician leadership. And so that's why it was a really good fit. My mom and dad still live in Wilmore, and they probably also had tears, not about UK basketball tickets, but, and so they were glad, because they're actually patients of the Lexington Clinic. So it was kind of this cool thing where I could come back and oversee the doctors and take care of my mom and dad. So that was part of my thinking as well.
Thank you. As said, I'm Bob DiPaola. I actually recruited here 8 years ago. The role is new, and obviously it sounds like a complicated thing when you have a health system in a university setting. So the title is Executive Vice President for Health Affairs, and I do that in conjunction with Eric Lundgren, who's the university's head of administrative finance. And we'll talk earlier about how we synergize together over that. But I was actually recruited almost 8 years ago as the Dean of the College of Medicine. Prior to that, I was in New Jersey. I actually headed one of the health areas at Rutgers. I was their NCI designated comprehensive cancer center director for a number of years and headed the clinical operation here before coming here. Came here as Dean of the College of Medicine a couple of years ago. The reason for the Provost part was that the president asked if I would also serve as Provost, where we have actually 7 healthcare related colleges in addition to additional colleges. We have 17 colleges overall. And then this past year in terms of the role of the health system. In terms of personally, we love Lexington. Came here, my wife and I, as empty nesters, 3 grown boys, one of them still in school up in the Northeast. And actually, over the course of 8 years, we have brought all 3 of them here, their significant others, and they all live in Lexington at this point. But then,
to our here.
but to top it off, the only remaining relative I had personally was my mom in New Jersey. This past year, we moved her to Lexington, so we are thrilled to be here. Look forward to further discussion and help with the workforce.
And I gotta make one, I've been in this industry 35 years. Some of the most competitive industries and individuals and companies are in healthcare. What you're seeing, the interaction here, they genuinely like each other. And I'm not trying to be funny. I mean, typically in communities, especially between the university, which is where I've mostly been in the settings, and the private, it's ugly. And they typically on a stage like this, you'd have a couple, 4, 5, and they would have those smiles, and you're thinking, it's not a smile. It's genuine. So anyway, the fact that you all connect and I connect, we're going to learn that here. And some of the questions in your comments, I think, will tell you how fortunate we are as well. Mark Turner put together with the group of our staff some key questions. So I'm going to start with those. I would ask that you all be thinking of questions that you've got so that towards the end of our question session, we can get your questions answered as well. Okay, so this is going to be a question for all panelists. Each of you are relatively new in your current position. How much of an adjustment did you have in your new role, and what attracted you to the Lexington region? Let's start with Bob.
I'm happy to do that. So, just like I was saying a little while ago as well, I got attracted here in terms of the dean position at the College of Medicine. Talked to you all about bringing family here as well. I think in terms of the role, I trained as a medical oncologist. Actually, I did my medical oncology at the University of Pennsylvania, and then went to New Jersey. Like I said, always in an academic environment, academic health system. I love the opportunity to bring new discovery into the clinic. So it was a bit of my emphasis for a number of years. And so the dean role is an opportunity to do more of that across many disciplines beyond cancer. In that role, though, you also have a seat in the executive committees of the UK healthcare. So I got even more excited about the healthcare end of things. So I would just have to say, in summary, putting it all together, all those missions in terms of education, research, and clinical care in an integrated way was what just always excited me. It also creates an opportunity to have partnerships, meaning what we can do from the standpoint of an academic health system to create more of a pipeline in terms of the healthcare workforce that we're all needing to share and continue to grow. And then the same thing for the discovery end, so that we can bring more of cutting-edge opportunities through the research that we have and get that out in various networks in Kentucky and especially in Lexington. So very much enjoy all of those different aspects. Well, I don't know if I should tell you this is a longer story, but I'll try to be brief. When they first go through the recruitment process, they brought me in an airport interview in Cincinnati, so I never actually got to see Lexington. I won't go through the long story, but I ended up pulling out, telling them what it sounded great, but wasn't that interested. I got all kinds of calls to say, would you at least come to Lexington? Came to Lexington, and it was probably a few hours. I had a break, called my wife, and I said, this is pretty incredible. So, we got excited. We saw the region, we saw Lexington, obviously saw the campus. President Capelouto had already done an incredible job in terms of transforming our campus, and it just continues to grow. So,
That's good to hear.
Absolutely.
Yeah, for me, growing up in Lexington, I was somewhat familiar with the healthcare community, but not totally familiar with the healthcare community. And so, having been gone away to Columbus for a while, one of the things I noticed was the physicians in Columbus tend to be single specialty large groups. So all the GI doctors are in one practice for the most part in Columbus. All the ENT surgeons are in one practice in Columbus. All the radiologists are in 2 practices in Columbus. So it makes for a very siloed patient experience because you have to jump from one practice to another practice to another practice. And so when I came down to Lexington and I saw the Lexington Clinic, I remember thinking to myself, I'm not interested in this job because I have a pretty good job in Columbus. if they're going to be fighting with each other, if they have a really crazy competitive culture with each other. And it blew me away how the physicians appreciate each other. And I remember the surgeons talking about their primary care colleagues in a very positive framework, very, very positive light. And for me, that was kind of refreshing, because in Columbus, it didn't happen that way. Like, the surgeons are surgeons, primary care doctors are primary care doctors, and they kind of stay in their own little lanes. And so this integrated multi-specialty dynamic at the Lexington Clinic was really attractive for me, because I was coming out of a single specialty practice in hospital medicine. So I'm an internist in internal medicine hospitalist. And so the opportunity to work in a group that's integrated and highly collaborative, I agree with Bob, that like the way that Lexington and folks work together and collaborate, there's competition for sure at places where competition has to occur. But at the same time, it's highly collaborative. And in fact, at the clinic, we actually work with every health system here. We work with UK's Markey Center, we work with Baptist, and we work with CHI. So it's both competitive and collaborative, but the relationships are incredibly strong. And so I think that's really, really attractive for Lexington.
Tony?
As I mentioned, have family roots here. Just to back a little bit more about that backstory, St. Joe's has been in Lexington. It's Lexington's first hospital, 1877. My family in Rochester County, my father, as a 12-year-old, was tragically hit by a car and didn't think he was going to make it, and they rushed him to St. Joe's in 1964. And my dad spent 10 days at St. Joe's, being literally put back together, multiple fractures, head wound, etc. Lexington Clinic surgeons actually operated on my father at St. Joe's. So in a weird kind of full circle of life, I'm not here at St. Joe's. So there's a real call for me. Maybe about Chris, I saw it from the outside because I was in the system. Certainly knew people, certainly had that family connection. But for me, there's a real attraction to do good in this world, to call to healthcare. I'm not a clinician. I've been doing it my whole adult life. Went to Xavier. My first hospital was a Catholic hospital, so I'm really drawn to our faith-based ministry. And I kind of pinch myself. I get to do this kind of work, try to improve the health of people we serve, with really incredibly smart people, like you see on stage here, and to do it in a way that I can express my faith fully when I do it. So for me, that really connects. I tell you, of course, I knew Lexington, right, as I shared. But now being here, working here, seeing groups gathered like this, I credit Bob and what Commerce Lex is doing. And maybe you know this, in St. Joe's, we're part of a regional system. It's not just Lexington, We've got hospitals throughout the Commonwealth, we've got clinics all over the state. And so we do think regionally. We absolutely have to think regionally. Not only about, the way we're structured, but who we're caring for. And I think that's the power of what happens in Lexington, is we treat people from all over the state and beyond the borders. And so we're very fortunate, Bob, you said it, to be here, to be gathered here, to have this expertise in Lexington, but we are regional. We care for patients everywhere. And our workforce is regional. We'll hopefully get into that as well. So for me, it's a real connection. Yeah, for sure. Real connection of my history, my faith, and the ability to work with some
Yeah, and similar to what Tony said, so we, with Baptist Health, most of you know we're a 9-hospital system throughout the whole Commonwealth of Kentucky. So having worked in the various areas that I did in Louisville and the range of Paducah, I was very familiar with Lexington. We always used to have a lot of meetings over here as a health system. I was really, Lexington wasn't strange to me at all. It wasn't foreign to me. It was very familiar to me. But it's been a good ride. I've been here 2 years. We've really enjoyed Lexington, and we've enjoyed the arts, the sports, the people, the hospitality. So it's been a wonderful city to be in. What some of the challenges, I think that was part of the question, is what were some of the challenges when I came here. I have very good friends that left Baptist Health. One, unfortunately, Bill passed away, and Karen Hill retired. So when you look at that equation, they've been here for decades at Baptist Health in Lexington. I knew them very well, but those are the two leaders really that everybody knew at Baptist Health in Lexington. And so it's almost like my daughter was 3 when my son was born. We brought him back, from the hospital, and my daughter was kind of like, who is this guy? Who's this new baby? I was the new baby, basically, here at Baptist Lexington. But it's gone very well. It's been very welcoming, and we have a really good team.
So COVID-19 was a very difficult time for the community, for the region. We know it's also an extremely difficult time for your teams and for you all. that still, no matter where you were at, healthcare is totally relied upon. So this question is going to be for all four panelists, but what did you learn how the industry and your facilities handled the pandemic? And did you change anything operationally to deal with any, with another pandemic in the future? And why don't we start here?
Actually, I was going to say, I was here as Dean of the College of Medicine when that all started. And obviously, we all had to figure out how to deal with decisions in an unprecedented time. We didn't have all the data. Things changed. And people lose track, or I lose track too, of the fact that, at the beginning, people didn't even know, whether they use masks or not, or you wash your hands, or, and the data was emerging. We moved pretty quickly. We had to deal with it from the perspective of a health enterprise on campus. So we had a lot of employees across the campus. We had to move everyone to remote, immediately. We identified that vaccination was key. We set up in Kroger Field, everybody knows, just an incredibly large operation. I think we ended up with 250,000 vaccinations through that period of time. I mean, just a massive operation. The thing that we saw was people coming together, and we had so many volunteers, including a lot of the colleges. I went and volunteered too, to make sure that we were giving people, the opportunity. We made moves across campus, obviously, as we started getting people back, masking and so forth. We didn't mandate vaccination on the campus, but we did enough in terms of incentives that we were over 90% vaccination rate on the campus as a whole. In the health system, we obviously needed to require vaccination, at least through that period of time. We learned a lot about enhancing what we needed to do in telemedicine. We learned that we could do it. We could do it more rapidly than we thought. It was interesting because we had already been working on trying to increase our telemedicine capacity. And prior to COVID, we were seeing all the difficulties of enhancing it and various things that we would need to do it. But boy, when COVID hit, we just all moved, and we moved faster than we thought. I think post-COVID, we've learned a lot about how we pay attention to things, and we don't keep the databases that we had before in terms of COVID rates and so forth, but really paying attention to what's going on in the campus instruction and education. And I would say, just ending in terms of this particular topic, that education and awareness was key. So really getting communications out on a regular basis was absolutely critical. So people weren't as scared and fearful, meaning as the evidence came up, we got it out there in terms of the importance of safe masking, the importance of vaccination, et cetera. Just those kinds of activities. The other component, though, we leveraged. I mentioned before some of the things that we can leverage in a university setting is the research end of what we have there. We worked together a team, a STAR team of experts in research on the epidemiology and the public health, and actually under public health here as well, all at the table, meeting actually weekly and then sometimes almost daily as evidence was coming in and we were looking at what was going on in other systems, both healthcare and university campuses, and then making recommendations to the campus. I got involved early on because as Dean of Medicine, the president asked if I would chair that. We actually still have that problem. We just don't eat very much, just over other respiratory viruses that come. So we had kind of research, evidence-based experts advising the campus, and then implementation teams to just be sure to implement. Appropriate field in terms of the vaccination, our communications group in terms of education. Massive effort. I would have to say though, we did it in many collaborative ways because we connected with the community in so many different ways. Many different companies and so forth in terms of trying to, give education or look at best practices in terms of what everybody else was doing as well. We learned a lot.
Thank you.
Let's say, for me, I was in the hospital when COVID hit. I was in Columbus. And so the speed and agility the healthcare system had to adapt with was incredible. It's everything Bob was talking about. Doing things we've been trying to do for a long time, like for years, like in 4 weeks or whatever, 3 weeks. What was weird was we were hearing about this coming from Italy. We were hearing about it hitting the East Coast initially, but in Ohio it wasn't hitting it. There was nothing there, but we're ready for it. And then it sort of started trickling in, and then all of a sudden, this massive wave hit, and we weren't really ready for the wave. And we were spinning up ICUs like within 48 hours. Like, hey, we need a new ICU. This unit's not an ICU, what it is now. So all these nurses are now ICU nurses, and all these doctors are now ICU doctors. We're not ICU doctors. No, you are today. So it's that type of a dynamic of speed that was unprecedented. And the other thing that I remember was how fast patients deteriorated. They come in pretty sick, kind of sick. This is the alpha wave, which is the very first one. And it was, you look at them and, okay, they're stable, sick, and then 6 hours later they're dead. And it was just unbelievable. Like, what is going on? What disease process does this? And you see all kinds of system failures. Like, it wasn't just the respiratory system. They're coming in cardiac failure. They're coming in liver failure. They're coming in, what is this thing? And so we're trying to figure out, do you use steroids? No. Wait, no, we do use steroids, and all of that type of thing. So there's a lot of uncertainty during that time. So the agility and speed to react to it was difficult. But what I think is super interesting is here in Lexington, but also in Columbus, how the health systems actually collaborated during COVID. We were on calls, cross-system calls, all the time. What do you need? We need masks, we need things, whatever. And certain people have certain, we have ventilators, or we have masks. And so you begin sharing resources, because in that moment, we were all on the same team. I mean, we may compete again at certain times, but man, we were all on the same team during COVID. And there's this unified front, almost with the state, leading us into like how we're coordinating our care to get through COVID. So I think that that speed, that agility, and that collaboration was really key parts of the healthcare system.
Just pick up on a couple points. We were all kind of in different places, but all in COVID. So I was in Tennessee when it started, and we were kind of watching Kentucky. It was a different approach here, just in the collaboration. Not that we weren't collaborating in Tennessee, we were, but at a different level. So the community, the state level, the leadership at the governor's office. So when I got here in April of 21, of course, we were still pretty good into the epidemic or the pandemic. Vaccines had just come on board. We had a huge wave that hit us that summer, that fall of 21. And because we were talking to each other, every day we know how many patients each other had, where the ventilators were, where the infusions were, what we needed to do, where the drugs were released, how we would get them, how we would split them with each other, et cetera. So it was incredible collaboration. What I love about that is I'd like to do more of it. So sometimes the government helped us. They did help us there. But now, we compete, so we're not allowed to share things. We're not allowed to do things together. So we need to continue to lean in and see if we can press on that because we're better together and patients get better care. One of the things too, as I mentioned, I love working in a place where really, really smart people around us. We're scientists at our core. We learn a lot. We continue to learn a lot. As Bob said, there's research. We're still learning. On the pick up on the telehealth piece, and maybe we'll get into this as it relates to the workforce, is we accelerated some things that had always been working on it. We've been working on telehealth. At St. Joseph, as you know, we touched lots of places in the Commonwealth. We have patients in rural places that travel 2-3 hours to get to our physicians. We can now see them quickly through telehealth, and it was really well accepted, continues to be well accepted. As part of a national company, we've asked our company to keep trying things in Kentucky because we want to go, and we've got the ability to do it. So we've taken that expertise in telehealth, and we do it now in virtual nursing. So we have one of our units here in Lexington that we have nurses that aren't at the bedside, and they collaborate with our nurses that are at the bedside, and they offer more touches and more healing opportunities for the patient while those nurses are moving throughout the unit. It's fantastic. Now, we can do it because we know the technology, we know how to activate through telehealth, and our patients understand it because it's not the first time they've ever seen it. So we're just pushing into a new environment that hadn't existed before. So I think those are the things from COVID for us. We continue to let ourselves understand that we know how to learn, we know how to learn fast, we fail fast, we learn fast, we keep each other safe, keep our patients safe. I'll close on this point. What excites me going forward, you ask about are we prepped? Yes-ish. What I mean by that is, that was a novel virus. We certainly had seen coronaviruses for a long time. We had some idea. What was exciting to me in looking back, Steve said we were losing patients that were confusing to us. They were young, healthy otherwise, and they were literally dying within hours. What did we learn from that? We've got to be open to continuing to learn and try. And I'd say to have a vaccine within a year of that thing showing up is incredible. It's hard for me to fathom it So I'll close on this, is I would try to say to our team, what we prove to each other, I think, as humans, is we can do really hard stuff when we put our minds to it. So we just gotta keep putting our minds to it, breaking down barriers so we can really smart people can collaborate and fix things fast.
Thank you. So, yeah, very similar to what was already said, but yeah, the industry, we became very, very nimble, as was mentioned. And we just touched on telehealth, that was key. And what would have taken years, it seemed like it took weeks to advance in telehealth, and it's here to stay. As far as, we all collaborate. Part of my time was at Baptist Health Behnke when it first started, the virus basically. And yeah, a lot of collaboration. We're on weekly calls with my colleagues in Western Kentucky. I mean, you get to some serious situations where we're right in Western Kentucky, is a prison in Eddyville. And there was an outbreak with COVID there. It's like, yeah, because they're going to come to our ICU and we filled up about, I think, 8 or 10 beds in our ICU quickly. I was on the phone with my colleagues in Western Kentucky. We've got 10, how many do you have? So we all collaborated and took our share. Those were some serious, pretty frightening situations at the time as well. But I think, yeah, as an industry, we became very involved.
I know the business community was wanting information, and you all probably don't know it, but you all allowed us. Tom got us involved, plugged in. The mayor plugged us into the healthcare group that talked. I think it was weekly, sometimes daily. And that was very helpful because it also eased the tension for the business community to know that we have their back, but because we have our back.
About, I mean, I would quickly, what was different for me experiencing it here is you listened to us. It wasn't that way across the country. So when we asked you to not send people to church or don't put kids in school right now, you listened to us. You saw us as experts. Well, I'm nervous a little bit now as I see healthcare's been put in a different spot a little bit, where before we weren't really put in any political one way or the other. And it feels like now we sort of got put there because our jobs aren't red or blue or any of that. Our job is to take care of people. You did trust us, and I hope that we remember that don't take that for granted, that you gave us an opportunity to have a trusting relationship, and it worked here. It didn't work that same way everywhere.
Very good point. All right, we're going to hit a real tough issue right now. Everybody's probably knows what I'm going to ask. Can you talk about each of your health systems and how you're dealing with the nursing shortage? Have you changed anything in the hiring process? Where have you found the most success with nursing?
All right. Well, so I think I'll state the obvious. We did have and did rely on supplemental staffing to support our nurses in other areas. As you know, a lot of folks took the opportunity to travel. There's an opportunity in Colorado or California or somewhere they could go, and maybe we could live here for 9 months, see if we like it, come back to Lexington. But that took a toll probably on all of our hospitals. So what did we do to deal with it? We brought in travelers. And we do still have travelers. We're seeing the demand go down, which is a good thing, but we're not out of the woods yet. And I think just like everybody else up here, we did extra shift bonuses, incentives. We offered more vacation time to our employees, offered sign-on bonus to nurses coming in, those types of things. We beefed up our recruitment staff, added more recruiters so we could onboard faster. And I think those are some of the key highlights there for what we did, or are doing with the nursing shortage.
Yeah, like Chris said, we still have this temporary labor, this nursing folks that come and travel. That's probably going to be with us for a period of time. It's just where the market is. As you all know, market dynamics happen. That's much less than it was for sure. We try to be creative. Again, we're part of a large national capital healthcare system, and so we create our own internal group of folks that want to travel around to our different places. I mentioned to you about the telework that we do. So to be clear, in healthcare, just a side point, burnout is real. We give you statistics about where it is in our industry. It's an epidemic actually, and we lose people to suicide with our physicians and nurses, so it's real, it's stressful. And so we think about that. People took choice too to leave the industry, right? Folks got tired and can't blame them for that. So long and short, we got to continue to build a pipeline. I think we've done that well. We've been working with many of you, working with our schools of nursing, we're working with all of our feeder schools, not just our nursing schools, but we need every bit of healthcare. We need respiratory therapists, physical therapists, and laboratory technicians, et cetera. There's a shortage everywhere. So we have jobs, right? We can grow about it. We have plenty of jobs in healthcare. I'll speak for myself. So we just try to keep the pipelines open. And again, we're trying to challenge ourselves to think differently. I mean, if you come to a St. Joseph Hospital, we will nurse you differently than we nursed you 3 years ago because we've had to learn that. Our chief nurse and our chief operating officer, Dr. Melissa Vinitz, here with us today. If you have opportunity to meet her, she's nationally known as someone that leans in and innovates. She's done an incredible amount of programs in our health system to bring about what's new, and we have to keep doing that. So you're gonna think differently. I'm gonna turn it over to Steve. He may talk a little bit about efficiencies in workforce. We have to do that. Many of you have already done that in your businesses. Mary, this year we go to Fifth Third, we probably don't ever have to go into the bank anymore. We may not even interact with humans as much as we used to. We've got to think about that in healthcare too, because we have to trust each other to try the technology. Because this workforce shortage isn't going to be fixed just by more humans. That is something we need, but we've got to be more efficient. We've got to be leaning into new technologies. We've got to be thinking differently in the way we care for each other. So that's what we've been focused on at St. Joseph.
Yes, my comment is that the Great Resignation was real, right? And for nursing, I think it was real in the business community as well. It did affect every other sort of space also, rad techs and other folks. And it's one of those things where in healthcare it's difficult because you're coming into a field where you can bring a disease home and kill your family, right? So it really, during COVID, it was really challenging for a nurse, especially a bedside nurse. The people that were wearing the totally enclosed, gear, the PAPR systems, they were the nurses. The doctors could be outside of the room and look in, and we got glass on our side. We'd look in to see the patient, but the nurse was in the spacesuit inside. If they had a procedure, some of the doctors would go in the suits and stuff like that. But my point is that weight was real, right? They're taking that home to their families. The stress of that's real. So in my head, nursing will never totally go away. It can't. And we just have to think about how do we support them as they do this work. And I think that it really raised that issue of what does it mean to be a bedside nurse? What does it mean to be a rad tech or a ventilator, pulmonary tech, respiratory tech? And so I think we do have to work on how they do their work, how we help them do their work, how we help them in their careers to make them value added so they don't, carry that burden in the same way. And so that raises the question like, how do you leverage AI? How do you leverage new technology tools so that maybe they spend less time documenting and more time caring? Like Epic, as people know, we have these big EMR systems called Epic, which are really, really challenging systems to work in if you're a staff person. There's thousands of questions that people have to work through, different people, different roles. And so when you're wondering what the staff are doing clicking, well, they're trying to fill out these forms so that we can make sure we're providing good care. But does a person actually have to fill out all those questions? Is there a better way to do those questions? And in my mind, is how do you leverage tools like AI to maybe answer some of those questions with the ambient listening or other things where those questions can be answered as we go through. And even these telemedicine, telenursing programs, part of what that is helping people document, helping people capture the patient's disease state correctly. Because we want to know what's happening to patients as they're getting this care. We don't want just a blank piece of paper or like doctor's handwriting, right? Like when a doctor used to write a note, you couldn't read the darn thing. So Epic helps us because at least you can read the darn thing now. But it still takes a lot of time to enter all this data into these systems. So I think we're going to have to think about how we leverage our staff, what we're having them do, and how can we use the technologies to actually support them as we go forward.
I would say we're experiencing some of the same things. We tend to think about it probably in 3 categories. The first would be pipeline or training those that would come and be part of the workforce, since we have that opportunity. Actually, we have our Dean of Nursing here as well. And so we've been increasing the number of seats in terms of nursing. So and I think projected, at least over this next year, just within the 1 year, we're going to increase the number of RNs by about 50% in terms of those that we have seats, so that training will increase. And then another program where anyone who's had prior coursework or say associates to get them more rapidly to an RN status or a bachelor's in RN status in a more rapid manner, and we're planning on doubling that in terms of those numbers as well. So pipeline is really important. One thing I'll also say is it helps all of us, because if you actually looked at the numbers, we have quite a few that come to UK Healthcare, but actually more go to other systems. So we need to really pay attention to that pipeline. The other area that we're paying attention to is collaborations. We have many 2 years of schools out there in terms of the community colleges in our systems where they might have an associate's degree, and that's an opportunity to recruit them with an associate's degree. But then given some of the programs to bring them into a full bachelor's degree, this way we have a full range of expertise in nursing. So there's a lot of work being done in our college of nursing and under UK Healthcare as well in terms of that. The second area is recruitment. You heard a number of the strategies in terms of recruitment, making it attractive to come here. We have something in the order of 2,200 overall nurses, but about 600 of those are travelers, to the point made. Some of them are coming from other states. We want to do everything possible to attract them to want to stay here. So we have a lot of work in terms of educating them, giving them opportunities to understand how great it would be to stay in Lexington, obviously in any of our health systems as well. And so we actually have a program where we're trying to put together packages where they can transition from a traveling nurse to a full hire more permanently. It makes it much easier, much better for somebody to be there for a long period of time, because then they learn the system, they learn the expertise, they learn how to interact with. We heard before the importance of healthcare, working with a team. And then the third area is retention, and you heard some of the strategies as well. We're paying a lot of attention, like you heard from our colleagues here, and their various expertise within their systems, paying attention to well-being. We need to, it is stressful out there. It was stressful through COVID, and there is a lot of burnout. We already heard about the increased suicide rates and so forth. So we're paying a lot of attention to the day-to-day lives of the nurses that we have. The other thing we're doing to make their lives better is looking at it more holistically, because it's not only do you recruit nursing, but all the staff around them. If you recruit, for instance, certified medical assistants, they can help with the workload so that some of the nurses don't need to do every single thing, and so forth. So we're looking at a number of different things. In terms of kind of the components that actually help with all of that, I'll just finish with this. We do pay attention. I know we all do with loan repayment programs, and then again for the pipeline tuition assistance programs, so that it eases the burden, so that more individuals who have a passion for nursing feel they could financially go into that path, even though it may take a number of years for them to train. So we're going to keep working on pipeline, we're going to keep working on workforce, we're going to keep working on recruitment and retention like you've heard here.
And I would just point out for all of you, the 4 individuals up here in their institutions are very much plugged into our 9-county regional initiative. And a big part of that is going to be on the workforce component of retention and recruitment. We have 70,000 students in a 40-mile radius of Behnke County, and we have quite a few of those folks are graduating each year, and we need to do a better job of keeping them. But as you pointed out, nurses, traveling nurses, when they come in, families, connecting them in. So we'll be working very closely. Yes. Well, we're better together, and that's one of our big themes as we go forward. So now we have a question. I'm going to aim it at each of you individually, and we're going to start a little bit tight on time, thinking of questions. But I got one for you, Bob. You were recently named co-executive vice president for health affairs along with Eric Behnke. Can you talk about that shared role and how it's worked since you were both in a co-active role since December of 2022?
Absolutely. It is probably a bit of a unique structure, although I can tell you, talking around the country, especially within health systems and universities, it's now talked about as a potential optimal structure. For me though, I've known Eric actually quite a while, so it wasn't like we were new in terms of our potential synergy. When I was asked to be part of the president's cabinet as provost, he and I worked together quite a bit with the president, and so we had a couple of years of synergy in that role before taking on the role together overseeing the health system earlier this year, enacting our interim role. And it was only August that it was made as a permanent role, because we were seeing that there was a real synergy. You know, I think, you know, Eric handles more of, first off, we work on strategy together. Obviously, we do that in alignment with the university, with the president, work on strategy together. And as we all talk about, and the president talks about as well, once you have strategy, you then need two areas of focus: infrastructure and talent. And, you know, and Eric does a lot of the facilities and finances, or the infrastructure end, although we do it together, but he leads that. I lead more of the clinical operations and the programmatic areas. What are we doing, you know, with cardiovascular? What are we doing in cancer? And how do we build those transdisciplinary teams? So I think in regard to that, we communicate a lot. I would say that, you know, we did even over the past prior years. So communication is critical. We're texting back and forth. We shared offices that 6-month period where we were doing an interim. But I think it's been very synergistic. I can say that from a clinical operations perspective, from a leadership perspective, I'm able to move faster. I think from an infrastructure perspective, he's able to move faster so that we can make decisions more rapidly. So it's actually worked out pretty well. I wouldn't have thought about it, years ago, but it's actually worked out very well.
Excellent. Steve, Lexington Clinic is Central Kentucky's oldest and largest group practice. And you recently opened a brand new 116,000 square foot facility on South Broadway, and you got another project rolling up right in front of our eyes. How has this new facility enabled Lexington Clinic to better serve patients, and what are some of the cool new bells and whistles inside the new facility?
Yeah, good question. So access for us is a big deal, and it was really challenging to get patients into our old building. And the old building needed to go away. For those of you that were in the old building, it had served its time and purpose, and it's now gone. And we appreciate the service it gave us, but we need new space. And so the new building, the main new building, does give us a lot more access and space for patients to come in. You know, our focus is on efficient multidisciplinary care, right? So a patient can come in very efficiently, very quickly, get seen by numerous specialists. The building we're building next door, for those of you who have seen it, that's going to be an integrated building as well, where it's neurosurgery, orthopedic surgery, pain medicine, physical therapy. So basically a patient can come in, get seen by one set of physicians, and theoretically get seen and treated by another set of physicians in the same day. And that's actually really, really hard to do in most healthcare systems, to get multidisciplinary care nearly simultaneously, nearly real time. And so these buildings will really allow us to do that on the same campus. And so that's pretty exciting for us. As far as bells and whistles, we don't have any bells in the buildings per se. I don't think it was alarm bells or whatever, but all of our imaging is actually in the same building. So the MRI machines are there, the CT scan machines are there. And in the future, we'll be having the ability to do procedures in the same buildings. So for like pain medicine, you can actually do the intervention right there in real time in the same building. And so that's really what it allows us to do.
Excellent. Chris, can you tell us about the timeline for the completion of the Baptist Health Hamburg development, and what it will mean to the system and central and eastern Kentucky, and how many people will be employed there, and what services will be included?
So, yeah, we're excited. The Hamburg facility, we're going to open at the end of April. So actually this month, construction will be complete, and then we have to fill it all in with the furniture, fixtures, and equipment, such as the CT scanners, the MRIs. It takes a lot of time to just put those in. We can't just walk in the door and plug them in the wall. So we'll spend the next 4 months getting everything loaded in there, so we'll be ready for the end of April. So what services will be there? There will be a freestanding emergency room, and within there will be 24 ER exam rooms, if you will, and then 24 we call it clinical decision unit beds. Essentially, we're not ready to send that patient home yet. You keep them here a little bit before we decide whether we need to ship them to Baptist, Lexington, or for admission we'll send them home. So that's what that. When I say clinical decision unit, that's what that is. There will be a cancer center there, so we'll do infusion therapy and radiation therapy, so we'll have a linear accelerator there as well. And then we'll have a surgery center. So right now, the surgery center is at Fountain Court, right off Man of War. That'll close and move down the street to Hamburg. So those 3 key services right there, ER, cancer center, and the surgery center. We'll also have a medical office building there with physicians, orthopedics, urology, gastroenterology, et cetera. So we'll fill that up as It's about 400,000 square feet. Probably see it as you drive on I-75 there. We excellent access for I-64 and 75 and patients coming from further out. So we're excited to get that rolling. But it's the most ambitious project right now for the Baptist Health System. Yeah, I think it's going to be great for the community. We're really excited.
Right, we've talked a lot about how well you want to get along and interact, and you made the case overwhelmingly that that's just part of how life has to be and to be successful. But Tony, can you tell us about the recently announced partnership between CHI, St. Joseph Health, and Lexington Clinic, in which Lexington Clinic will provide physician staffing within the CHI, St. Joseph Health System? And then how did this partnership come about, and how will it impact your health system?
Thanks, Bob. As mentioned earlier, Steve mentioned in 1920, the clinic started. St. Joe's in 1977. We've been doing this a long time across the street from each other in different buildings across different streets over time as we move. We're one health system across the Commonwealth. So as Dr. Behnke mentioned, all of us are on the Epic system. It's a little different in each of our health systems, but nonetheless we have that common record. It's we're again trying to use technology across all of St. Joseph. So we think about everything we do at St. Joe's. We try to make sure we deliver exceptional health care, compassionate health care, make it a great place to work and practice. We think collaboratively across all of our 100 locations in the Commonwealth, not just about what happens in Lexington, what happens in London, what happens in Australia. So to that end, we've really taken a lot of focus about delivering clinical expertise similarly. So if anybody shows up anywhere at St. Joe's, they can expect the same. And just in conversations with our physicians and ultimately with Dr. Behnke and his expertise, we had an opportunity to think differently about our emergency departments, the way we deliver care. It wasn't the same everywhere. And to be honest, we were using a national team that were good, but they weren't as connected to Kentucky as we were. So long and short, we're just exploring opportunities, and with Dr. Behnke's vision, he said, well, let's think about this together. We want to, again, learning from what we did with COVID and just the way we try to work together. We were working in silos. We said, can we just think differently? Again, now we had a record on all campuses that was the same. So we went to work on developing that very quickly. And we've been incredibly thrilled with the product that we delivered. As you know, healthcare is complex, and we're always learning every day, as I mentioned earlier, but the emergency departments, especially, there's 7 emergency departments across St. Joseph. And the clinic now, there's clinic staffs all of those with their providers. And it's amazing to see what the team has done. They leaned in, they thought about things differently. And so the changes they make at our adjustment facility are important changes they learned from it. And those are activated across all of our campuses. Our East facility makes a change, it's activated everywhere. And so we just haven't had that synergistic opportunity. And we're excited about that. As we mentioned, we got to do more of that in healthcare. We got to learn faster. So I'm really thrilled with thank Dr. Behnke for his taking a big risk to think about it differently. We all kind of thought, let's try this. Let's go about some synergies together, and it's been wonderful. So more to come. Keep feeding back to us. ED medicine's an interesting place, right? See everything, do everything there. And so we've heard really good feedback from not only our patients, but our providers. It's a better place to work, and a better place to practice, and we're thrilled for it.
I've got a very personal question to raise, and it's going to affect everybody in this room in a very significant way. The UK Martin Cancer Center is the first and only center in Kentucky to earn a National Cancer Institute Comprehensive Cancer Center designation. Can you talk about what this designation means and why it's important for UK and the Commonwealth?
Yeah, absolutely. As Dr. said, the Cancer Center itself gets designated, obviously, by NCI. The highest level of designation around the U.S. is the status of a comprehensive status. It's taken 13 years, but they finally achieved that this year. So they were designated by the National Cancer Institute. There are only 56 throughout the nation, so you can think about all the cancer centers. But they're really here for the state as a whole. In fact, when cancer centers get reviewed, they have to define all of the areas or the regions that they are to help. And so this is, a state cancer center. It interacts with other cancer centers, and it provides, some unique services, especially on the research end. So research opportunities to network out, so clinical trials and so forth. And I'll just give one example. Because of the research that's going on in genomics these days, I think everybody knows, you've heard of 21andMe, or whatever the thing can get your DNA analyzed, and it will tell you whether or not you should drink coffee before you go to bed, or what drug you should be careful of, those types of things, metabolizing caffeine and so forth. Well, genomic sequence has been done over the last decade for cancer, and a lot of the new therapeutics, the very best therapeutics, are guided by an individual's DNA in their particular cancer. So very individualized medicine now, especially in cancer. It's happening actually beyond cancer now, quite a bit. But Marky, with the researchers, you have basic scientists who understand gene changes, sitting at the table in what they call a molecular tumor board or a precision medicine clinic, sitting at a table doing DNA analysis on a patient's cancer, and then making recommendations along with the physicians, the pharmacists, you know, and a team, as we were talking about, a multidisciplinary team, making recommendations on the best absolute therapy for that particular individual. It's often a combination of therapies. The other thing is by getting NCI designated, they get grants where they can get a pipeline. They're getting a pipeline of the newest drugs that are coming right out of NCI, National Cancer Institute. National Cancer Institute navigates and negotiates with various companies to get those drugs. So what it's doing is it's bringing a pipeline of the newest agents, the cutting-edge therapies, to Kentucky, and then deploying it in different ways. And this molecular tumor board is one way to do that. In fact, what they're doing is they're now collaborating across the state. There are actually 19 health hospitals that they are having the opportunity in Lexington as well. And we have a direct relationship with Lexington Clinic in this regard, where any patient out of the community could send their samples over to Marky. Marky's expert team reviews it, makes recommendations on what the best therapy would be for that particular patient because of their particular individual cancer. But that requires just this incredible research. And at this point, I think they're up to about 60 million or so in research awards that come from external awards. So what it really offers when you think about Lexington, what it offers in terms of the state, is bringing in a pipeline of agents and drugs and opportunities in terms of cutting-edge therapies we wouldn't have here. But their mission is to deploy that in a collaborative way out there. So we're going to continue to work on more networks and opportunities so that anywhere in the state, certainly within Lexington, when we're right next door to each other, they have those opportunities in terms of research reaching those patients in various networks. So I think going forward, in fact, their external advisory board came through yesterday, and it was somewhat celebratory because they were all congratulating Dr. Edwards, the director of the Cancer Center, and all of us for achieving that status. But the external advisory board basically says, okay, now you're there, you got to take it to the next level. The next level for them, from a national perspective, is you got to get it out more in the community. So you'll see more efforts from Marky trying to have additional partnerships and ways where any of the things that they're doing that might be unique and offering patients something that could be deployed outside in terms of other health systems are going to be accomplished. So we'll see that over the years. Hopefully that kind of answers it. I mean, there's a lot more to the Senate. The Senate's fairly large. I mean, over the last number of years, or the last 5 years, I think they recruited about 100 researchers. So it's really that research base getting out into the clinic and the community, and it's such a complex disease and such an individual disease that every aspect of care is just critical.
Thank you. Questions for the audience? Yes, sir.
One of the initiatives that the Affordable Care Act has done is push for increased price transparency. So that is now very much coming back into focus. So I'd be curious kind of what price transparency, what you all are doing to improve price transparency for the consumer, and maybe how difficult or easy that might be to put in place.
I'll start and Steve can jump in. So just a quick basic healthcare 101, our prices are crazy, right? So it comes from just an old way the way we were built. We actually do cost reports, all of us, and send in those, well maybe Steve doesn't have to do it, but hospitals do. We have to send cost reports to CMS, and through that, there's various equations that happen that come back, and that's how we ultimately set the price that Medicare pays. Once that Medicare price is set, everybody else goes off the Medicare price at some percentage. And so it's just an old antiquated system that quite honestly is very difficult to be transparent within, to be honest. Nonetheless, we have passed national laws to require all of us to put our prices out there to be transparent. We've done that, we comply with that. If I might, Scott, take your question a little bit differently, what I would say is there needs to be more transparency between how the economics of healthcare actually happen. And just if I might, we've got a collection of business leaders here. It's broken. Healthcare reimbursement is absolutely broken. So I'll speak for St. Joseph Health. About 70% of everything we do is government. About 50% is Medicare. The other piece of that is Medicaid, and then commercial is 30%. Our margins are made on the commercial side. The government doesn't pay us enough to cover our costs. Simply don't. At St. Joseph over the last year, 12% inflationary increase in our labor costs. Right? It costs a lot of money to hire people, and it costs more now because they've asked for sign-on bonuses and tuition reimbursement, et cetera, et cetera. So we've done that, we've invested that. So we've been around again 145 years. We got a big balance sheet, we spent it. So that 12% inflationary cost, I got to get it out to the market. It's very difficult because I have to get it to you through an intermediary, the insurance companies. And they're not real interested in giving us more money. Yeah. So I'd be interested if you all get double-digit increases from them this year, and we don't, we need to have a conversation. So I know I didn't quite get to prices, but economics in healthcare is crazy. There's no other place in our industries or in the industries you lead. You know, our patients come to us, we have to treat them no matter what. And I'm grateful that we all do that. Bob just talked about, we have an NCI designated cancer center in the Commonwealth of Kentucky. That's fantastic, but that's not cheap. So we all have to understand the economics of healthcare, and I feel like the transparency piece, we got a lot more to do to help each other understand how it actually works.
Other questions?
Yeah, just to kind of go off of that same question, but with more seniors who are electing Medicare Advantage plans over traditional Medicare, can you talk about the challenges that you all are facing in healthcare generally and what you're doing to address those challenges with that shift?
So, yeah, and you've probably seen in the news that Baptist Health has given notice to the Medicare Advantage plans. They, our challenge with Medicare Advantage is you can have a patient come in to our hospital for 11 days, end up in our ICU, they get septic and die, and they pay us an observation rate. What we've been dealing with Medicare Advantage is this delay, deny, and don't pay, so to speak. So we are at the table with some various Medicare Advantage plans to work some details out with them. We're trying to get really to where traditional Medicare is. That's our challenge with Medicare Advantage.
So I'll make a comment that, Medicare wants to move 100% of their beneficiaries to risk-based models by 2030. Probably 2033 or something, push it back, I'm sure, but 2030 they want people to risk-based plans. So I think what the government's basically saying is we've got to get more efficient in healthcare, we've got to have more effectiveness in healthcare, more quality, more value. So I think at the clinic, we're focused on how do we remove waste from the system, right? And it's not that people are bad, rather it's our processes are somewhat antiquated. The system's how the money moves, all this sort of things. It sort of sets us up for the system we're in a sense. Regardless, it doesn't matter. We've got to remove waste, we've got to make it easier, better, faster, and cheaper. And so if we can truly bend the cost curve, this is what's exciting about Kentucky. With such a high Medicare, Medicaid rates, if we can get to hyper efficiency, we can actually show the country how to do this better. Because if you're in a state where you have really good payers, i.e. Colorado, you just don't have to work that hard. And I would argue Medicare, medicine back 30 years ago didn't have to work that hard. There's a lot of money in medicine, there weren't a lot of patients necessarily at that time. It's not that way anymore. We're having to work faster with less margins. We have to get more efficient. And the way we do that is make better decisions with better information. So again, back to technology, what can we do to do this work more efficiently? So for us, we're full into Medicare Advantage. So if we're going full risk. Lexington Clinic will be full risk in Medicare Advantage in 2024. So 1 month from today or so, we will be full risk with Medicare Advantage, which means we're working with the payers to take all the risk and manage the patients more fully. So it's about getting the right patient to the right place at the right time for the maximal outcome. Because the problem is, patient shows up in the ER, the system's kind of architected to put him in the hospital. Well, that may not be the best place for that patient to get care. Why not at home? Can we get nurses to go to the home? Can we get nurses to do things different? Can doctors do things with telemedicine differently to take better care of patients? And so I think it's an opportunity. We're going to have to figure out how to do this as time goes on, but it's, in my mind, it's about maximizing efficiency and removing waste.
And I'll just add as well, I agree with everything that was said. And, you know, we're all working very hard at improving efficiencies while maintaining quality. And the other thing we're having to do is hire more and more staff to help from a patient perspective navigate all this. You know, they're seeing that cost and they're not knowing what's going to get covered, and sometimes they're showing up and they're not sure in terms of, and some of these therapies are just incredible in terms of, I mentioned even before, some of the newest therapies, just incredible in terms of prices. So we're having to do more and more to even help patients and hire those individuals to help patients navigate the system, so to speak.
Let's thank our panelists. Some individual questions that you may want to ask our folks. WealthSouth, Jeff, thank you very much, and our other sponsors. Look back at your program there. We appreciate those folks, and for all of you for coming out this morning. The world's changing, especially in healthcare, and we appreciate to have the four of you in your leadership roles and just how interconnected you are with us. We value that an awful lot. Thank you all very much. Have a great day. We need the rain, though it may be kind of hurting hitting the roof a little bit earlier, so hope you get umbrellas. But enjoy your day, and thank you for what you do for us.